Thanks so much, and thank you all for taking the time to complete your polling questions, as they will help inform our final webinar in November. So welcome to this Priority Health Innovation Challenge webinar. My name is Neil Dreimer, and I'm so excited to be joining you today as the host for today's session. I would like to start by first acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are hosting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. I also suggest that for you to feel free to use the chat box on the bottom right side of your screen to tell us who you are and the organization that you work at and where you're joining us from. I also wanted to let you know we are pleased to host all Priority Health activities, including this webinar, in both official languages. If you wish to view today's slides in French, please let us know in the chat box now. The telephone number to connect to the French audio will be on the screen once you are transferred to the French room. At any time throughout the webinar, please feel free to chat in your questions using the chat box in either French or English. We have reserved a few minutes at the end of the webinar for Q&A, but please pose your questions as you go. All right, so with that, I think we'll go to the next slide, and I do not see the next slide toggle on the screen, so thank you, producers. So as we are getting close to the end of the challenges, we want to step back today and look at the big picture. Later on in the webinar, we'll be hearing from two of our supporting organizations, CIHI and CCSA, on measuring and improving access to care in mental health and addictions and home and community care. Next slide. Okay, so it's now my pleasure to introduce today's speaker. Joining us from the Canadian Institute for Health Information are Jenny Lineker, Program Lead for Emerging Issues, and Shauna McMartin, who is the Program Lead for Indicator Research and Development. Joining us from the Canadian Centre on Substance Use and Addiction is Amy Porak, Director of Research. Welcome, Jenny, Shauna, and Amy. Next slide. So I'd also like to give a shout out to my colleagues on the challenges team, Lindsay, Sabrina, and Emily, who you will find today in the chat box and are your go-to people if you have any questions. Next slide, please. So what do we want to do by the end of today's session? Well, you'll have an opportunity to hear more about the challenge, welcome our new teams, and learn about the final two award opportunities. You'll also learn and hear from two of our mini challenge number 3 award winners as to how they've adapted their work during the pandemic. And of course, you'll hear from our colleagues at CIHI and CCSA. Next slide. So just a picture here to let you know we are now in the home stretch for our Priority Health Innovation Challenge journey, and we're almost at the end. Next slide. And a reminder that the Priority Health Challenge is supported by 20 supporting organizations from across Canada, including CCSA and CIHI. Next slide. So I am so pleased and so excited to extend a warm welcome to our 10 new Priority Health Challenge teams who you can see on this screen, which is, I'm going to have to guess, that's probably a record. And so we're really excited to have folks both in the home and community care sector and mental health and addiction sector. So you can see 5 of them on this screen. And then if we go to the next slide, Another slide. That's amazing. So a warm welcome to all of you. And if we go to the next slide, you can see our map, which really helps illustrate the 33 priority health teams who are joining us to highlight all the great work they are doing to innovate to improve access to mental health and addictions and home and community care across Canada. Next slide, please. So we're so excited to share some more information about two of our remaining challenges. So on the slide here is the Impact Challenge Award. This is our second last challenge, and it really aims to capture the impact of your project on patient needs and outcomes, as well as an opportunity for you to summarize your patient reach and outcome data to date. Next slide. So this gives you a little bit more information about some of the questions we'd like you to answer in a maximum 3-page report. Next slide, please. And this just helps you understand that there are, if you apply for this award, there are up to three awards of $10,000 available in each category: mental health and addictions and home and community care. To apply, we need to have your report into us by September 30th, and it has to be submitted to our online portal. Next slide, please. So here you can see a little bit more information about our overall challenge award. Next slide. And really this challenge award aims to capture the progress of your project over the entire Priority Health Challenge period. It asks you about your innovation and why it was developed, the impact of your project on patient needs, quality of care and providers, and how you have served more people with your initiative. It also asks you how your project has improved access to care in mental health and addictions and home and community care, which of course are the two main themes of the challenge. Next slide, please. So here's a little bit more information about what you can win. So there are a total of 7 awards to be won. One overall award winner will get $60,000 to the team that has the overall highest challenge award score. There will be 3 awards of $30,000 in the runner-up category and 3 booster awards of $10,000 each. And as a reminder, if you want to apply for this final award, you need to submit this report into the online portal by October 20th. So, and that's just a key thing. Make sure you submit it to the portal, not through any emails. But if you have any questions on either of the 2 awards I've just described, feel free to connect with the Challenges team, either in the chat box now or through email, and they'll share the email. Oh, they already have, I can see. Thanks, Sabrina. Next slide, please. So it's now my pleasure to announce the winners of our mini challenge number 3. And just a reminder, this challenge was really focusing on and giving the choice to teams to submit either a project improvement charter or, given everything that's happened with the pandemic, a report on how teams have adapted their work over the last few months. So a warm congratulations to all the winners of the Alberta Health Services Edmonton Zone, the Enhanced Home Living Project, Body Brave and Eating Disorders Nova Scotia, CVI Home Health, CHEO Family Navigation, the FAST team from Joseph Brand Hospital, Pasco Mental Health, the Hope Model team from SE Health, Sunnybrook Family Navigation, the virtual psychiatry collaboration team from Providence Health, and finally, Yorktown Family Service. So congratulations, all of you. Next slide. All right, so enough of me talking. So before we dive into our presentations today, we'll have an opportunity for a brief chat with two of our mini challenge number 3 winners who you just learned about. And so we'll learn a little bit more about how they've adapted their work during the pandemic. I'd like to now welcome Zaina Kayat from SE Health, one of our home and community care teams, and David O'Brien from Yorktown Family Services, one of our mental health teams. Welcome to you both. And
hello.
Zaina, I could see, hi Zaina, I see you're on the phone, so I know you just got here, so thanks for making it. And hi David. Zaina, maybe I'll start with you. Could you describe briefly your initiative, your elevator pitch, and how you've adapted it during the pandemic?
Yeah, so before, in the before times, we were about a year into what we expected was a 4-year effort to try to transform how home and community care is delivered in Ontario, but in Canada, and really taking inspiration from the Brutzorg model, and maybe someone can put it in the chat from the Netherlands. That's now scaled to 25 countries, including Kaiser Permanente is transitioning their whole home care system to that. So we wanted to get on that journey for our org and our whole health system. So we started by testing, a model that removes fee-for-service. Nurses are empowered to make whatever decisions they need to for their patients in the field in real time. Digital first, so all data is captured. You can measure outcomes in real time, pay people on salary, pay them more. I mean, everything that's wrong with home care, we were testing in a kind of a laboratory. We had one site live, about 100 patients in North London, and then we had just set up a Toronto site, and we were doing a rural site near Waterloo, and then COVID hit. So the adaptation is 2 of our sites we couldn't get off the ground because priorities had changed with our funding partners and local partners, and then our one site in London actually decided to double down and keep going, add more patients, and extend even longer than we had planned. So that's where we're at with that. And of course, with COVID, we had to go a blended virtual, physical, pretty much overnight. But because we were digital first, we were ready. We didn't have to scramble and teach our nurses how to work virtually. So that was a great thing about the project.
Yeah, that's wonderful. And I definitely, I know lots about the HOPE model and the great work that you guys are doing. And but absolutely, I can imagine that the foundation of a digital total would have been a key enabler to pivot. David, maybe I'll go to you next. Can you describe a little bit about what your project is, and also how you've managed to adapt during the pandemic?
For sure. Once again, thanks for having us. I'm from Yorktown Family Services. We are a multi-service mental health and social service organization based in Toronto, and we serve people from birth to the age of 35, primarily around mental health and addictions. So over the last several years, we noticed that children and youth leaving inpatient units in hospitals, in particular crisis units, children going to and youth going to emergency departments, where some great work can be done, both inpatient and outpatient services in hospitals. We noticed that when they were transitioning back to community, there wasn't really a whole, was not place for them to go at times. If there was a place, it would often fall through the cracks in terms of the transitions between the hospital and community mental health. So about a year and a half ago, through a few foundation grants, we were able to develop a model, a care navigator, as basically a staff that's hired by us to be embedded within the hospital to transition people out from inpatient and outpatient units in particular, and sometimes emergency departments, so that recommendations from hospitals could be carried through within the community. We noticed that over the last year and a half, we've had about a 90% success rate of youth remaining in community care and not returning to the hospital. And we've began to expand that to other hospitals in West Toronto. So that integrated connection, and when children and youth come to us, they're then signed or moved into integrated services hub that we have, which has a variety of mental health, social health programs, therapy, youth outreach, and of course groups, psychoeducation groups, trauma treatment, and a whole host of about 32 services. So early March of 2020, while watching the pandemic from afar and thinking it would never happen in Canada, a state of emergency was declared halfway through March here in Ontario. And we weren't virtual at all, actually. So we were very sort of in person, primarily 90% of our services. We did have a plan to move virtual probably in about 3 to 5 years. And, that was certainly an organizational goal. So quickly we had to mobilize our entire staff team of 80 staff and begin to learn how to do virtual services. So we received some training. We purchased some IT products to make that happen. And probably by the end of March, early April, all 32 programs were actually 100% online through a system called NewTalk, where we were also using WebEx too. And then, of course, parallel to that, developing policy and procedures and training people while transitioning children and youth from hospitals. I have to say, none of us probably slept for a couple of months, but we certainly, I think, pulled it off, and we've been quite successful in continuing those relationships. In fact, expanding our relationships with hospitals. We now have Toronto Western Family Health Team on board. And basically what happens is that when we receive a referral from the hospital, we can contact them through a video conferencing system that we have called NewTalk, which is a privacy-protected system here in Ontario. And then we then integrate them through what we call our virtual integrated youth services hub, which has all the same programming that we did in person that was now converted to online programming. And recently, just because that mechanism may not work for all patients, what we have now done is prioritize clients that need to be seen in person. And of course, using all the physical distancing protocols and reshaping our space to do that. So we sort of have now the best of both worlds. One of the silver linings of the pandemic was that it really forced us to escalate our virtual services quite quickly to get that in place, and not waiting 3 to 5 years, but certainly, being able to do that, just because it was just an absolutely essential thing to do for us as an organization.
No, wow, talk about rapid innovation. So, no, thank you, David, for sharing more about the experience and how you managed to change so quickly. I'm sure there's lots of lessons learned in there. We don't have much more time, but Dana, maybe I'll just ask you a final question. Do you have any tips on what you've learned from rapid innovation during the pandemic and how with the HOPE model?
God, that could be like a 4-hour webinar. I will say, I think, when you go into an improvement effort, and I think the support of CFHI has been great for us, with an intention to spread and scale, the kind of team you recruit and the processes you have for how you do your work will set you up for that. And I think because we had done that, we were able to adjust very, very quickly because we recruited the kind of nurses who are ready for that, and we built digital from the beginning. So I think that might be a lesson is, any future shock perturbances, and they're going to come, we know they're going to come, the investments you're making now to have good foundations of adaptability, flexibility are going to serve you really well. And I think I'm appreciating that from our experience.
Wonderful. No, you're right. We could spend the rest of the time today on rapid adaptation and innovation, and then I think our last webinar was on that. In the interest of time, we do have to move on, but once again, thank you so much, David and Zaina, and feel free to chat anything else, any other insights into the chat box as we move along. So now we're going to go next to our colleagues at CIHI. So we're going to go to Jenny and Shauna. just to let you know, because we do have a packed webinar today, I will give you a 1 minute heads up near the end of the presentation just so that we can make sure we have time for our remaining speaker. And also, I know there's a bit of technical difficulties on advancing the slide, so if you can just say next slide so that our producers can move the slide. So over to you, Jenny and Shauna.
Thanks very much. Hi everyone, my name is Jenny Lineker, and I'm here today with my colleague from CIHI, Shauna McMartin, to provide you with an overview of CIHI's approach to developing indicators and to give you a bit of detail on some of the indicators that are in development as part of the Shared Health Priorities commitment. Next slide. In August of 2017, the FPT health ministers announced that they had agreed to work toward the common objectives of improving access to mental health and addiction services and improving access to home and community care. Our organization was formally asked to support the performance measurement commitments of the FPT agreement by monitoring and reporting on progress towards increased access in these areas over time. Next slide. After a lengthy consultation process, 12 indicators were selected for release over a period of 4 years, starting in 2019. Today, we will briefly cover those that were released earlier this year, and then give you a bit of more information on the indicators that are in development for release in 2021 and 2022. Next slide. Indicator development and reporting follows a very well-established process at CIHI. The development of the Shared Health Priority Indicators in particular involves a significant collaboration among FPT ministries, system experts, CIHI staff, and persons with lived experience. There are also indicator-specific expert advisory groups to advise on definitions, methodology, and interpretation for each. It's important to keep in mind that the indicators are a starting point to launch discussions about access and to help identify opportunities for improvement. Some of the guiding principles for the development process include building on existing work and refining the methodology over time, driving improvements in data quality by reporting what is currently available and then expanding what is reported as data coverage improves, and identifying important data gaps and working with jurisdictions to fill those gaps over time. Next slide. Results for 3 new indicators on self-harm, including suicide, caregiver distress, and new long-term care residents who potentially could have been cared for at home are available for the first time. More information on these indicators can be found on CIHI's website. Next slide. There are 2 wait time indicators, one for community mental health counseling and one for home care services, that are slated for release in 2021. Next slide. Both indicators are following the same timeline for development. As you can see, we have been working for a couple of years on developing and refining the wait time indicators. 2021 will be the first year of public reporting for this wait time information. Next slide. Our process for developing both of these indicators has involved many steps, including extensive consultations, engaging with persons with lived experience, and working with expert groups made up of representatives from the provinces and territories. We involve the jurisdictions on our advisory groups because the data for these indicators will be pulled directly from provincial and territorial data collection systems. After working with the expert groups to define the indicators, we collected preliminary data in November of 2019 and reviewed that data to decide whether any adjustments were needed to the indicators. The indicator definitions were finalized over the summer, and we're now currently waiting for the second round of data to be submitted, which will be the data that we report in 2021. Next slide. Because the wait time indicators are different from other shared health priority indicators and that they are based on aggregate data
that will be submitted to CIHI by provinces and territories, some additional principles that guided the development of these indicators are worth noting. From the outset, the aim was to define an indicator that would reflect a balance between the data that is currently available and what clients actually experience as a wait time. Given that not all jurisdictions have data collection systems set up to capture this information, provinces and territories will report as closely as possible to the agreed upon definition, and then any material difference between the indicator definition and the data that is submitted to CIHI will be noted as a caveat. So over time, our aim is to have fewer caveats as data from the provincial and territorial systems evolve. Next slide. So here's a look at an overview of the wait time for home care services definition. For this indicator, the clock starts when a referral for home care services is received by the organization that coordinates care and ends when the client receives their first home care service. We are measuring this indicator in calendar days, meaning that weekends and holidays will be included in the measurement. And the indicator will be reported as the 50th percentile or median wait time for all ages and all urgency levels combined, although we are going to be reporting breakdowns by age, by gender, and by home support versus home health to provide a fuller picture of the wait times. Next slide. And here's a look at the definition for the wait time for community mental health counseling indicator. For this indicator, the clock starts when a referral for counseling is received and then ends on the first date where the client agreed to attend. And this stop time was chosen in order to take a client-centered approach to the measurement. Again, we'll be measuring in calendar days, and this indicator will be reported as the 50th percentile wait time for all ages and all urgency levels combined, although we will be collecting breakdowns by age, by gender, and by fiscal quarter to provide a fuller picture. I'm happy to answer any questions on the details of either of these indicators at the end of the presentation, but I will now turn it over to Shauna McMartin, who will review the indicators in development for release in 2022.
Thanks, Jenny. Next slide. So I'm going to share a brief update on the new indicator we're developing as part of the Shared Health Priorities reporting in spring of 2022. Next slide. These fourth-year indicators were pushed out further than the other indicators because we knew these would be new measurement areas and would require some conceptual framing before we could recommend how to measure and where to seek data. The two of the mental health indicators that will be released in 2022, navigation of mental health and addiction services and early intervention for mental health and addictions issues in youth, are at slightly different stages of development. I'll be sharing a brief update on the development of the navigation indicator, and we will provide an update on the early intervention for mental health and addictions issues in youth as part of the post-meeting materials that will be circulated in an email from CFHI in early October. Next slide. Clients experience various pathways when seeking mental health and/or addiction support and services. These tend to be less well-defined than many physical health conditions, causing frustration, confusion, or clients leaving care or being lost to follow-up. With this indicator, we're trying to inform our understanding of client experiences of navigating between and within health services for their mental health and/or addictions issues. As with any health indicator, we're looking for a single point of measurement. Therefore, we must hone in on a single angle and acknowledge we won't be able to capture everything related to the broader question of system navigation. However, given the limited information or data related to navigation that's currently available, this single measure will be extremely important for us to start to better understand the systematic experience of clients accessing and using mental health and addiction services. Some of the possible options to capture this information that we've discussed in our expert consultation as well as consultation with persons with lived in their living experience are things like whether clients felt supported during navigation, the number of barriers the population faces when navigating between services, and themes that have come up are things like cultural safety, individualized care, choice, empowerment, and whether navigation was respectful to an individual's needs, values, and preferences. Next slide. So we have proposed that we frame the focus of our indicator development on a survey question related to identifying barriers to navigating mental health and addiction services. This aligns with the overall intent of the indicator. There was a lot of interest in this indicator not focusing on the traditional health administrative data route, and this would allow us to identify obstacles within and beyond the healthcare system. The concept of barrier identification resonated with experts and clients consulted. A lot of the client feedback focused on the barriers preventing them from accessing and moving between services. And experts in the field highlighted the preference of capturing barriers as a focus for indicator development. There are many different types of barriers, and it will be important when identifying barriers to measure as part of this indicator that we focus on barriers that will be actionable at a policy level within jurisdictions, as that is the target audience for this indicator. Based on the discussions and thinking back to the overall intent of this indicator, focusing on the system-level barriers may provide more insight for policymakers to action to improve access to mental health and addiction services. Our preliminary recommendation that we're working towards right now is to develop a survey tool that would include a set of questions that gathers information on the type of mental health and addiction services received, whether supports were in place to help the individual move within and between mental health and addiction services, and identify some of the system-level barriers that they faced when moving within and between mental health and addiction services. Next slide. So some of the next steps that we're working towards, so we have ongoing engagement with our expert advisory group to narrow the scope and develop the indicator definition. We're gathering input from persons with lived and or living experience on system-level barriers to capture. And we're working towards selecting a data collection option that will meet the needs of a population-based survey of persons who have used mental health and or addiction services in the last year across Canada. So we put some key questions for you that we'd like to gather your input on either at the end of the session, or if you have any thoughts or feedback, please feel free to share them with us via email at sharedhealthpriorities@kaihi.ca, which is available on the next slide. Thank you.
Thanks so much, Jenny and Shauna, for the great presentation. And as we can all see, a lot of work goes into indicator development, especially when it's at the pan-Canadian level. So I would just invite folks, and maybe if we can just go back to the previous slide just for a second, just to, if you have any thoughts or input on those two questions at the bottom of the slide, how might this indicator inform programs or initiatives to improve system navigation, and what are some of the system-level barriers that prevent people from moving within and between mental health and addiction services? We'd love to hear, and I'm sure Kaihi would love to hear your input, so feel free to email them or to also chat in any of your initial thoughts into the chat box, and we'll see if we can go over them later on in the webinar. And as well, I encourage you to continue to chat in any questions or comments you might have. I can see a lot of buzz already in the chat box. So with that, we'll advance slides, please, to next slide. Yes, okay, great. So it's now my pleasure to pass over the mic to Amy from the CCSA. And Amy, just a reminder, if you can just say next slide, and we'll advance your slides. Oh, Amy, over to you.
Great. Thanks so much, Neil. And can everybody hear me okay?
Yes, yeah, we can hear you loud and clear.
Okay, great. So hi, everybody. My name is Amy Flores. I'm the Director of Research at the Canadian Centre on Substance Use and Addiction, and I'm really pleased to be part of today's webinar, and I'm going to share with you a couple of projects that we've been working on that are aimed at improving access to substance use and addiction care in Canada. So if we could move to the next slide. Thank you. This is a brief overview. I thought I would very briefly introduce the organization for those of you in the webinar who may not be familiar with our work, and then briefly cover 3 different projects that we're working on, and then I think we'll have some time at the end for questions. So next slide. And then we can go to the next slide. So CCSA is a pan-Canadian health organization, and we were created by an act of Parliament over 30 years ago. And our mandate is addressing issues of substance use in Canada. In addition to our national role, we also have an international role as well. Next slide, please. Here we've presented just a visual of our 4 strategic core functions. So we provide national leadership. A big part of our work is building strategic partnerships. And in fact, we do all of our work in partnership with other organizations, different levels of government, academia, people with lived and living experience. And, you know, our viewpoint is that substance use is such a complex issue. It's too complex for any one organization to tackle it on its own. We also have a strong research mandate, so advancing research, synthesizing the evidence, and then mobilizing the knowledge. So taking that evidence and making sure it gets into the hands of those who need it in a timely way and packaged in a way that will meet their needs. The next slide, please. Very briefly, why this work matters, and I know that you know this probably won't come as a surprise for some of you on the webinar, but you know it has implications in terms of health, social, public safety, criminal justice. Our most recent data from our cost study that we just recently released indicates that substance use, the costs are $46 billion a year here in Canada. We know that substance use is a major contributor to major diseases, but we know substance use is preventable, and people with substance use disorders can receive treatment and they can recover. So next slide. And then this is a diagram just outlining some of the different areas of work that we engage in. So today I'm talking about projects aimed at increasing access to services, but as you can see, we cover other issues ranging from cannabis and alcohol to impaired driving. We have a strong monitoring and surveillance group within the research team. So again, just wanted to let you know that there's really a wide variety of work that we engage in at the center. So next slide. And the first sort of tranche of work I wanted to speak about is some of the work we're doing related to stigma. And then if we could just go to the next slide. Thank you. So stigma is the negative stereotyping of people and groups based on characteristics or behaviors that are perceived as being different. And it's been noted by expert Dr. John Kelly that addiction may be the most stigmatized condition in the United States as well as around the rest of the world. 8 in 10 Canadians suffering from substance use disorders report that stigma is a major barrier to their well-being, and it really prevents people who use substances from accessing the care they need to get well. Next slide, please. So we've been engaged in a series of interconnected initiatives aimed at trying to change the conversation and really emphasize, how stigma can prevent people from getting the help and supports that they need. So we've been having workshops across the country, all before COVID, of course, trying to raise awareness amongst individuals about stigma related to substance use, how the language we use can really have an impact. So simple things like instead of referring to somebody as an addict or a junkie, but referring to them as an individual with a substance use disorder can be really make such a difference. And I recall presenting at an event a couple of years ago that it was focused on cannabis, but you know, everyone kept referring to, you know, drug users and junkies, and I stood up in this room of 300 people, and I asked if we could just start using more person first language and language that wasn't stigmatizing, because it really can take a toll on individuals who are struggling to get help. We've been working on some educational modules. We've worked with Public Safety Canada on one for those working in the enforcement sector. And we're also working on a series of modules that we will be releasing in the coming months. Again, trying to raise awareness of stigma and promoting the use of language that isn't stigmatizing when talking about substance use and addiction. I have a picture of a couple of resources. One is of our stigma primer. Again, trying to help people overcome stigma through their language. And then there's a resource that we produced just showing examples of stigmatizing language and what can be used instead. So all of these resources are available in both of our official languages for free on our website. And so if you're interested in any of these, I encourage you to visit our website. And at the end of the presentation, I have the link on the slide. The other thing, very briefly, I'll mention is that we've also been working with post-secondary institutions and having students lead campaigns on campuses. And again, this has been very powerful, and we've been getting some very good feedback from these campuses about how impactful this work is. So we'll move to the next slide. And I'll briefly talk about an initiative that we call the Improving Treatment Together project, and we can go to the next slide. And this project is really aimed at improving experiences and outcomes of community-based opioid use treatment services for youth, as well as for their families, and for health professionals who are providing treatment services. And our overarching goal with this project is really to improve treatment retention for young people. So we're really pleased to be leading this work as part of a cross-provincial initiative with Foundry Central Office in British Columbia, Alberta Health Services, as well as local community partners in both provinces. And this is a 3-year project, and it's bringing together a diverse project team involving youth, family champions as members of the team. And we're also using what we refer to as a co-design framework that positions the stakeholder groups as the experts in identifying and designing solutions to improving current state treatment services. And we're developing youth-centered, evidence-informed health services interventions for opioid use disorder treatment and to support their implementation and evaluation with community partners. So next slide, please. So the team has hosted a series of co-design workshops with the youth, the service providers, and family members to try and identify what their top needs are. And on this slide, I've sort of indicated what some of the common themes were from these workshops and indicated sort of where those themes match up with the 3 types of stakeholders. And as you can see, there's some themes that have come up across all 3 of the stakeholders. Some themes are more important for youth, some for families, some for service providers. I don't think I have time to go through everything, but just to emphasize, what some of those key issues were that came up during our consultation. So the next slide. So following our co-design workshops with the 3 groups of stakeholders,
We're now in the process of developing resources for youth, family, and service providers, and we're working directly with them to develop these resources. So again, I don't have the time to go through everything, but you can see on the slide the different types of resources that we're working on. So, for example, in BC, they're going to be leading the development of a parent handbook. We're also developing, short educational videos, storytelling videos. And again, what's so unique about this co-design methodology is that we're working directly with the stakeholders to create these resources. So we are hoping to be testing them out with our local community partners early in 2021, so early in the new calendar year. So we're really excited about this work and how this is going to help to retain young people in treatment. The next slide. So the final project I wanted to briefly touch on are our competencies for professionals who work with people who use substances. And if we can go to the next slide. So there's a real need to provide Canadians with a more consistent quality of service from the workforce, so those who are working in the substance use and addiction field. And CCSA's workforce competencies support organizations, institutions, employers, service providers, and professionals to embed specific substance use and addiction core competencies. And in addition to discipline-specific core competencies that prepare health professionals for their respective fields, these competencies also support curriculum development, training, and education, as well as entry to practice. So we'll move on to the next slide. So we've been working with different subject matter experts, advisory group members, people with lived and living experience, as well as their family and friends, to take on a multi-year project aimed at updating our existing behavioral and technical competencies. And these updated competencies are going to reflect up-to-date knowledge and best practices with an enhanced focus on person-directed collaborative practice, trauma and violence-informed care, culturally safe and anti-oppressive practice, as well as the use of non-stigmatizing and well-being focused language. And the updated competencies and accompanying tools and resources are going to be released at the end of this fiscal, so in March 2021. And we're currently exploring how best to make updates in progress available for rapid access to the field as the workforce is responding to the COVID-19 pandemic. The next slide, please. So throughout our different consultations with our subject matter experts and our advisory group and our individuals with lived and living experience and family and friends, there were a number of themes that emerged from these consultations, and these are themes that we're directly addressing and rolling into the updates of our new competencies. So very briefly, there's going to be more of a focus on well-being, emphasizing the neuroscience of substance use and addiction, having a more collaborative approach with people with lived and living experience and their friends and family, and really trying to strengthen the role of these groups in the competencies. That's something we've heard loud and clear from our consultations, as well as removing stigmatizing language. And again, with the view that we are going to be working to increase access to care for those who need it. So I think we'll move to the next slide. And I really wanted to have a slide for those of you who are interested in keeping informed of some of our products and some of our work. I encourage you to visit the main website, so www.ccsa.ca. But I also wanted to draw your attention to some of the unique resources we have. One is our Addiction News Daily, daily mail out. So this is an email with news clippings focused on substance use and addiction. It's a free service, and if you register for it, you will receive a daily email from us just summarizing different news stories. We also have a podcast series called The Evidence, which profiles some of the work of our team, but also of partners from across the country who are doing amazing work. And then we also have our Send You alerts and bulletins. So this is these are some unique products that we have available that you can subscribe to. But for all the projects I presented on today, if you go to our main website, you can find their unique web pages, and there's an opportunity for you to send an email for the project to keep up to date on different updates. So thank you so much. I really appreciate the opportunity to share on some of our work. And Neil, I hope I've kept within time, and that there will be some time for questions at the end.
No, that was excellent, Amy, and thank you so much. And thank you to all of our speakers, because you guys have all been able to work with the limited time you've had and share so much. So we're now into our open question period. I encourage people to chat in any questions you have for any of our presenters, and if you could identify if it's for CII or CCSA, that would be great if it's not obvious. Amy, maybe I'll just start with you. I mean, you presented a lot of what's happening and sort of a lot of the great work that CCSA is doing. We know in the area of substance use disorder, there's really more need than services available, and particularly in the current pandemic environment. I'm just wondering if you can share one highlight of a program or a service that you've heard about that's really making a difference in improving access to substance use services, addiction services during this time.
Yeah, well, I mean, the big thing that I'm hearing now from a lot of different partners is virtual care, and how quickly we were able to pivot and offer different types of services and support through virtual care. And, you know, what I'm hearing is that this has worked great for some individuals. It hasn't worked well for others. It really depends on, you know, the type of service. There was something I was reviewing early this morning just indicating for folks who are who participate in Narcotics Anonymous meetings that they have found it to be so helpful going virtually and feeling more connected. And whereas, you know, other individuals who are, you know, needing, you know, withdrawal management services, that the switch to virtual, you know, hasn't been that helpful. So I think part of what we're trying to do now is, you know, pull together, you know, what we're hearing from these different groups, and we're actually, you know, going to be starting some research just looking to explore people's experiences with virtual care, you know, the good, the bad, the ugly, and also surveying healthcare professionals who are providing these services so that we can get a sense of their experiences, all with the view to, you know, improving and informing practice. So that's sort of what I'm hearing in a lot of meetings these days, and a lot of the documents that I'm reading. It really is focusing on virtual care and how this can help to improve access.
Mm-hmm. No, that's an excellent point, and I definitely heard that as well. And we've heard it a lot, even in David and Dana's work that they presented today. You know, it's definitely been an enabler, but it's all about making sure what is the advice for, you know, when it's best used and when it's not really the right approach. So I think lots to learn from there. Maybe I'll go to Jenny and Shauna at CII, and also there was some comments in the chat box with some responses, so I'll just read it out. Ashnor from MGH, Wood Green. It's important to understand the impact of mental health and addictions across healthcare services and delivery. How can we measure the impact of this? Wait times for home care services is not necessarily a good indicator. And Jenny from CIHI did acknowledge that we do have a wait time indicator for mental health counseling, but agree that wait times are not an impact measure. Hopefully the full suite can help address your question on impact. And Lucy from Stella's Place said she agrees with the comments on virtual care. I also think it's interesting that many of the patient satisfaction surveys about virtual care are administered by online platforms, so I wonder if that's exclusionary. So feel free to chat in responses. So maybe Jenny and Shauna, one thing that I noticed in looking at some of the results that you've shared, and there was one interesting one, about 1 in 9 newly admitted long-term care residents potentially could have been cared for at home. And I don't know about others, but that was kind of surprising to me. I thought, maybe, I don't know if you could unpack that a little bit more, because does that look at if the right services were in place, or is that not really distinguishing with what types of services, if they were available, would that help? So Jenny and Shauna, I think the operators will unmute you if you're on mute.
Your lines are open.
Yeah, hi there, it's Jenny.
Oh.
And actually, I'm actually going to have to look back at that, because the teams that Shauna and I are on at the moment actually weren't involved in the development of the first few years of indicators. So I'm looking to my team to jump in on the chat and help answer your question on that one.
That's no problem. And I know there's lots of different folks at CIHI who probably are involved. So even, after the webinar, we can go to you. I know we're at time, and the chat box is continuing to go. I think if there are additional questions or comments, feel free to also connect with the Challenges team, and we can definitely address some of those or route them to the right person. We've definitely packed a lot in today's webinar. I'm just going to go to the final slide. Next slide. So I just wanted to mention that we have added a great opportunity through an additional webinar on October 14th to get another chance to hear from some of the Priority Challenge teams, as they'll be able to present 5 slides in 5 minutes on their innovations and how they've been able to increase access. And we're also looking to invite several external stakeholders to help give you an opportunity to showcase the great work and spread it even further. And our final webinar will be on November 16th on celebrating success and maintaining momentum. So I'd just like to say a special thank you to all of our speakers today. Jenny, Shauna, Amy, Zaina, and David, really appreciate you taking the time. And please be sure to take a few moments to complete the feedback polls on your screen. Thanks again, everyone, and we'll talk to you soon. Stay well.